Well, thank you very much for having me here. It's been a great conference thus far, so hopefully I don't let the team down. So I come all the way from Gainesville, Florida, so it was a short 2-hour drive, same time zone, so it's in stark contrast to my experience last year, so welcome to Florida. So today I'll be talking about updates in both the evaluation and treatment of bulbar dysfunction with a specific focus on cough, which someone's illustrating quite nicely, and airway protection mechanisms. So just a few disclosures to start with. A lot of this work was funded from the National Institute of Child Health Development. So I'm going to move pretty quickly. I have a lot to cover here, so I'll get going. And first I'd like to start by talking about screening dysphagia in ALS. So as we all know here, dysphagia is highly prevalent in individuals with ALS. What we're looking at here is a modified barium swallow study. And we see a pretty typical pattern here of aspiration, which is going below the level of the vocal folds. I'm not sure if this is a laser pointer. Nope. And you see a lot of residue there in the pockets in the throat, in the vallecula, and the piriform sinuses. And we know that malnutrition confers an almost 8 times increased risk of death in individuals with motor neuron disease, and it leads to compromised pulmonary status. And pneumonia was actually identified as a leading cause of death on autopsy at this meeting last year, a nice poster presentation by Burkhardt. Of course, we can't tell if they were aspiration pneumonia events or general pneumonia. And finally, dysphagia or swallowing impairment in ALS has been associated with social isolation, fear, decreased mental health. So this necessitates early identification of at-risk individuals to ensure optimal medical management, safe oral intake, and pulmonary function. So dysphagia screening in ALS. Typically, the American Academy of Neurology and the European Federation recommend ALS patients to come to multidisciplinary clinics. I'm preaching to the choir here, and this has been noted to increase survival and quality of life, particularly in those with a bulbar onset of the disease. And early identification and appropriate treatment with feeding tube placements have been noted to increase survival in a number of studies. But the challenge as a clinician is to accurately identify at-risk patients and to determine if further evaluation is warranted. At the multidisciplinary clinic I work in, we have 15 minutes of which we have to evaluate speech, swallowing, referral for AAC evaluation, and of course we're dealing with a lot of important psychosocial issues and education time points. And so it does become a huge challenge as a clinician to make sure that you're adequately screening these patients. It's also further compromised by the high incidence of silent aspiration or ALS patients who aspirate without a cough response. So what are characteristics of a useful screening tool? They must be quick, efficient, easy to administer and score, valid and reliable, and pose a high sensitivity and specificity. So we wanted to look at what is the utility of patient self-reports, as well as the utility of cough screening. So the first study I'll highlight, this was just published in the Journal of Neurogastroenterology and Motility. And the aim of this study was to determine what is the discriminant ability of a validated patient self-report dysphagia scale that is quick and easy to administer to identify unsafe swallowers in ALS. And this was defined by the presence of penetration or aspiration of material on video fluoroscopic evaluation. We recruited 70 individuals from the University of South Florida ALS Clinic, and here are their demographic information. And they attended one session, and we performed a video fluoroscopic swallowing evaluation, and the patients undertook the eating assessment tool 10. This is what this looks like here. It's a 10-item report where the patient rates on a 5-point ordinal scale the degree to which they feel they're having problems with swallowing pills, for example, solids or liquids. 0 would indicate no problem, 4 would indicate a severe problem, and there's a total score ranging between 0 to 40, which would indicate a normal or severe impairment, respectively. This is free for download. If you just Google Eating Assessment Tool 10, you can download one of these here. And then we used the validated Penetration-Aspiration Scale. This was done in a blinded fashion by 2 experienced raters. And on this scale, a score of 1 to 2 would indicate safe swallowing. A score of 3 to 4 would indicate that the patient is penetrating at or above the level of the true vocal folds. And a score between 7 and 8 would indicate that the patient is an aspirator, so material is entering the trachea below the level of the folds. These are the statistical analyses that we did. And moving along to the results, we found here, this is group mean data of ALS patients who were safe swallowers, those who penetrated, and those who aspirated. And as you can clearly see here, the ALS patients who aspirated had a 5 times higher EAT-10 score on average than those folks with safe swallowing, and this was statistically significant. And interestingly, the aspirators had an approximately 3 times higher EAT-10 score than individuals who penetrated, which was also significant. So we did receiver-operator characteristic analysis, and using a cut point of a score of 8 on the EAT-10, we found that this cut point had a sensitivity of approximately 86%, a specificity of 72%. It had if a patient scored 8 or higher on the EAT-10, they had a 3.1 times more higher likelihood of being an aspirator than a non-aspirator, and this had about a 96% negative predictive value. As an exploratory question, in a subset of patients, we had the caregivers complete the EAT-10 score, the EAT-10 scale, while the patient was in radiology receiving their videofluoroscopic evaluation. And similar to patient information, we found that ALS caregiver ratings were significantly different between aspirators and safe ALS swallowers, as well as aspirators and penetrators. And when we compared the relationship between patient and caregiver ratings, we found that these were highly correlated. And we found that this was quite interesting, particularly in instances where an ALS patient's communication abilities have been diminished. The caregiver or spouse might be a useful informant. So in conclusion with the EAT-10 study, the EAT-10 was able to differentiate swallowing safety groups in ALS patients. If an ALS patient aspirated, their EAT-10 score was 5 times higher or worse than safe swallowers, and it was 3 times higher or worse than penetrators. The EAT-10 demonstrated good discriminant ability for the detection of penetration or aspiration. And the ALS caregiver may have a role in dysphagia symptom reporting and evaluation. This could be a particularly important factor in rural health and telemedicine practices, particularly when ALS communication skills have deteriorated. And we believe that the EAT-10 is a quick and meaningful aid for dysphagia screening in busy ALS clinics, for identification and referral of dysphagia patients for further instrumental evaluation. And this is just one piece of the puzzle, of course. This is not the be-all and end-all. We actually have started sending this screening tool out to patients, so most of them arrive to clinic with it already filled out. So moving along now to dysphagia or cough. And it's funny because I'm hearing a lot of coughs in the room right now. I'm trying to switch it off. And so dysphagia is another term for disordered cough. And here are just 2 clips of ALS patients and their ability to cough on command.
Okay, George, can you cough for me like there's something stuck in your throat?
So cough screening for aspiration has been used in other patient populations. Just briefly, in Parkinson's disease, Teresa Pitts and Karen Heglin have documented differences between PD patients with and without dysphagia. It has also been noted to have a high sensitivity and specificity for detecting aspiration, as well as decreased cough sensitivity and a reduced urge to cough in PD patients. And similarly in stroke, voluntary cough and reflexive cough testing has shown good discriminant ability to predict aspirators versus non-aspirators. To date, however, no group has looked at the utility of cough screening for the identification of unsafe swallowers. Therefore, we aim to determine the discriminant ability of voluntary cough airflow to identify the presence of penetration or aspiration in ALS. And for those of you who are less familiar with what a cough waveform looks like, it has three specific phases: the inspiratory phase, which is marked by a peak inspiratory flow, the compression phase, and then an explosive, hopefully, expiratory phase where we see peak expiratory flow as well as a measure of expiratory rise time, the time it takes to get to the peak. And there's a specific ratio known as cough volume acceleration, which takes into account the peak cough flow divided by the time it takes to get to that, and that's sort of a surrogate measure of cough strength or power, and I'll come back to that measure later. Similar to the last study, we did a between groups ANOVA across airway safety groups and receiver operator characteristic analysis. And interestingly, we found that specifically measures during the expiratory phase of cough were different in safe versus unsafe ALS swallowers. Specifically, ALS patients with unsafe swallowing had half the peak expiratory flow rate. Unsafe swallowers had almost double the amount of time it took to reach this peak expiratory flow rate. And their cough volume acceleration was 1/3 of the amount on average in unsafe ALS swallowers. And here is an image here. On the left, you see a non-aspirator, and on the right there, you see labeled a patient aspirating deep into the trachea. And these are just representative waveforms here on the same scale of time and airflow in liters per second. And you see a pretty vast difference there in these two coughs. When we performed receiver operator analysis, we found that cough volume acceleration was the best measure to identify unsafe swallowers. And specifically, cough volume acceleration had a sensitivity of 91% and a specificity of 82%. ALS patients whose cough volume acceleration was less than 45 liters per second were 5.1 times more likely to have unsafe swallowing. Peak expiratory flow rate also demonstrated good sensitivity and specificity. And in ALS patients whose peak expiratory rise time was greater than 80 milliseconds were about 3 times more likely to be aspirators. And finally, peak expiratory flow rate was significant for being able to identify unsafe swallowers. And those with a peak expiratory flow less than 4 liters were 3.4 times more likely to be unsafe swallowers. So just for the clinicians in the room here, we now have some nice comparison data to utilize in the clinical setting across ALS, stroke, and Parkinson's disease. So the expiratory measures of voluntary cough differed between safe and unsafe ALS swallowers. Specifically, their peak expiratory flows were 50% lower. The time to reach this peak was double the amount of time, and their cough effectiveness, CVA, was 3 times lower. Expiratory measures of voluntary cough airflow were significant to identify unsafe swallowers, and these may be useful parameters to evaluate during the clinical swallowing evaluation. Future work needs to examine the utility of reflexive cough testing in this patient population, and that's work that we're currently now doing. So now I'm going to move on the last part of the talk to the impact of expiratory muscle strength training on bulbar function in ALS. And we know that dysphagia, dystusia, and respiratory impairment are highly prevalent in ALS, and they are the cause of malnutrition, aspiration pneumonia, and respiratory insufficiency that together account for 92% of patient mortality. So there's a critical need for interventions to prolong these vital functions. And so earlier this year, I published a paper just sort of examining what could be the potential role of exercise in individuals with ALS. And it's interesting to note that there is not one single study investigating the impact of targeted exercise specifically on swallowing function in ALS. And when we look at airway protection profiles, in a convenient sample of 75 patients, we've noted that 15% of our ALS patients are penetrators, and 30% of them are aspirators. When we look at our ALS patients who aspirate, and I'll just show 2 examples here, very delayed and weak cough response, and there's material going straight into the airway. So this is a 5 ml amount, and you'll see that just going straight into the trachea there. They've been cued to cough. And having some difficulties there. And so what we have found in our aspirators is that 58% have an absent cough response, also known as silent aspirators, while 42% of ALS patients that we've examined have an ineffective cough response, with no ALS patient demonstrating an effective cough reflex. So this has brought about the recommendation for management strategies to improve vestibule closure, expiratory force generating pressures, and cough strength. And there is an intervention known as expiratory muscle strength training that in other neurogenic patient populations has been shown to improve subglottic air pressure generation, increase cough volume acceleration, and improve airway protection. So we thought, what about applying EMST to ALS patients to improve their functional physiologic reserve for the maintenance of breathing, swallowing, and airway protection? And this is a nice medical model from, not related to ALS, but I sort of like this model here. Number one, primary prevention. Can we do things to pump up the respiratory system in these patients so that they have a higher level of functioning to increase their physiologic reserve? And so we just published a paper in Muscle and Nerve in a, I'll move through this really quickly in the interest of time, but we documented that ALS patients, in 15 individuals with ALS, we were able to improve maximum expiratory pressures and some swallowing kinematics immediately following a 5-week treatment protocol. So we undertook a randomized sham control trial that was funded by the National Institute of Health, and here are our aims here. I'm going to move through this pretty quickly. Demographic information, we had 71% had a spinal onset, 20% bulbar, 9% mixed. And this was our protocol. Patients were consented and they underwent a baseline evaluation. Half were randomized to an EMST treatment, the other half to a sham treatment. They completed treatment sessions at home for 2 months, and a home therapist went to the home once a week to visit. They then underwent post-treatment evaluation. The sham treatment group were offered the active device, and then we did quarterly follow-ups of our major outcome variables. So just really quickly, we only had one patient drop. We did have one patient, when she crossed over into the active group, report symptoms consistent with a worsening of laryngospasms. However, we were not able to capture these in the clinic. Here is our outcome data. We saw a 27.5% improvement in our active group. This was significant. And then we also had a significant difference at our post-treatment outcome point between the sham and the active group. And we saw about a 6.7% improvement in our sham group. Looking at individual responses here, we had on average close to a 30% improvement in maximum expiratory pressures. And when we pulled apart the data, there were 3 patients whose maximum expiratory pressures over the 2-month period went down. There were about 4 patients whose MEPs we classified as sort of neutral. They either were plus or minus a 10% change. We had 32% of our active group had an improvement in their MEPs between 15 and 35%. And then 41% had a greater than 35% improvement. So essentially 73% of our active patients improved greater than 15%. This is just an example of a patient whose cough spirometry was significantly improved following the treatment. And another example of a patient here. We're currently going through, we just wrapped this trial a few weeks ago, so I'm currently having sleepless nights and wading through a lot of data, but I'm just showcasing obviously 2 important patients that improved. So to conclude, a 12-week regimen of EMST was well tolerated and led to improvement in maximum expiratory pressures in 73% of patients. We need to determine the impact of subsequent disease progression and factors such as hospitalization and aspiration rates. If anyone would like, we have some patient resources that we use in our clinic that are free for download. And I want to acknowledge the following team. And then finally, we dedicate this work to a group of individuals that we have worked with that at our clinic that unfortunately have passed in the past year, so we dedicate this line of work to them. Thank you.
Thank you, Emily. She left no time for questions. She used up her entire 20 minutes. But I wanted to let her go just so you know why. I wanted her to complete her presentation so it will be on the website and her contact information will be on the website rather than rushing her through her conclusions, which is never useful. So please follow up with questions with her later, okay? Thank you.